Assalamu alaikum and welcome to the Medical Black Book. Our today's topic is
Emergency neurosurgery. This includes the skull fracture, the extradural hematoma, the subdural hematoma, and brain damage to the brain tissue. In the skull fracture, the fracture can be either closed linear fracture, skull base fracture, fracture involving the sinuses, or depressed fracture. If it is a closed linear fracture, it could be treated conservatively. In a skull base fracture, complications that can be caused are CSF leakage, pituitary dysfunction, arterial dissection, cranial nerve defect, and anosmia, along with facial palsy. Treatment for such as no need of antibiotic prophylaxis, CSF leakage resolves spontaneously, and blind nasogastric tube should be never used. It is contraindicated. Whereas in fracture involving the sinuses, open fracture when occurs, treatment for this is broad spectrum antibiotic with or without exploration. In a depressed fracture, this occurs by when you get or receive a hit by a small object with high velocity on the head. Treatment of this is exploration, debridement, elevation, and later on prophylaxis. In extradural hematoma, this is a fracture of the skull which ruptures often an artery or a venous sinus. The most important artery which ruptures is the middle meningeal artery. This is a very surgical emergency. If the person has received this artery ruptures when the person receives a hit on the temporal bone. The patient presents with a lucid interval, headache, without neurological deficit. At this stage, as compensation has occurred, so there is no increase in intracranial pressure. After some time, there is loss of consciousness, ipsilateral pupil dilation, and contralateral hemiparesis. This suggests decompensation in which the brain has been compressed or is either herniated. We can see this on a CT scan. On a CT scan, what we see is there is a lentiform like appearance around the brain parenchyma. This is a hypodense lesion between the brain and the skull. The area of mixed density suggests active bleeding. Treatment is prompt evacuation. In our next emergency is subdural hematoma. This can be either acute or chronic. In acute, the cause is rupture of cortical vessels due to high energy mechanisms. The patient presents with, the common example is scoop or contracoup injury. This patient presents with conscious level impaired deterioration. It deteriorates further as the hematoma expands. We can observe this on a CT scan, and on a CT scan what we see is a diffuse concave appearance. Treatment for this is evacuation and conservative monitoring of the intracranial pressure. Whereas in chronic, this is seen in elderly whom are on antiplatelets or anticoagulants, with whom has a previous history of fall. After a few days, the blood clot degenerates, which leads to osmotic expansion, which causes the mass effect, and this later on in the elderly presents as headache, drowsiness, neurological deficit, or seizure. We can assess this also on a CT scan. On a CT scan, what we see is hypotensity on the brain tissue. Treatment of this is drainage with burr hole. If the patient is stable, we can delay this procedure about 7 to 10 days to allow platelet function to normalize. After that, withdraw aspirin and anticoagulants, and the effect would be reversed by given vitamin K or transfusions. If there is injury that is received, then this can be traumatic subarachnoid hemorrhage and collapse after the injury. We can see on CT scan angiography for diagnosis. In cerebral contusion, there is coup or contracoup injury with the bony prominences of the skull, and CT scan appearance as heterogeneous brain matter. In diffuse axonal injury, it is seen in high energy accidents that render a patient comatose. On post-mortem, there is hemorrhagic foci in the corpus callosum and the dorsolateral root. Management to prevent secondary injuries. First of all, what we need to do is we need to control the intracranial pressure. How can we do it? The initial management is that position of the head should be 20 to 30 degrees in a tendon bird position. Collar should be loose, not to interfere with venous return. Ventilation should be provided to prevent hypoperfusion, and sedation by opiates and barbiturates. Intermediate Maye. It's by giving the patient mannitol. This has a diuretic effect. Approximately 10 ml with 20% mannitol bolus is given when the pupils are dilated or unresponsive. This suggests herniation. Do not use it repeatedly as it can cause hypovolemia or hypertension. Drain the CSF by EVAD or by cooling to decrease the intracranial pressure, or heavy sedation is given. In the final measure, we do a decompressive craniotomy for the removal of we do this by removal of part of the skull vault, example by unilateral or bifrontal surgery, so that the brain swelling can occur without increase in intracranial pressure. The bony flap should be placed in the abdomen and replaced weeks to months later. Or for management of uncontrolled intracranial hypertension, we use thiopentone induced coma. This carry high risk of complications, hence we do not use it frequently, and there is loss of normal EEG and the pupil response is lost, so the patient can be considered dead for all you know. Hence we do not commonly use this. In stage 2, we have to assess the pituitary dysfunction, electrolyte imbalance, and brain swelling can also result in seizures. Third thing is we have to assess seizures. Seizures may occur in weeks or even later. The risk factors are due to intracranial hemorrhage, depressed pharynx, or tear of the dura. Treatment of seizures are antiepileptics such as phenytoin. And later, nutrition. Nutrition of the compensated within 72 hours by enterofeeding. Prokinetics, metoclopramide promote absorption are also given. Then we move towards the next topic, which is aneurysmal subarachnoid hemorrhage. This is associated with vasospasm. Etiology of this aneurysm is that aneurysm develops due to ineffective infiltration of arterial wall, which is seen in IV abusers or infective endocarditis. The risk factor for this is age, female, genetic disorder, in adults with polycystic kidney disease, fibromuscular dysplasia, neurofibromatosis type 1, Ehlers-Danlos, Marfan syndrome. The clinical features of subarachnoid hemorrhage are thunderclap headache. This is very sudden and very severe. It is that type of headache that has been never experienced. It is unlike the migraine which normally patients have. Patient may have prodrome of headache. Can be associated with seizure, unresponsive, vomiting, focal deficit, and impaired conscious level. The neurological exam is normal. Grading of hemorrhage is done after resuscitation. Grading is done by Glasgow Coma Scale, and it is the grade for classifying subarachnoid hemorrhage are the following. If in grade 1, Glasgow Coma Scale is 15 and the focal deficit is not present or absent. In grade 2, it is 13 to 14. The focal deficit is still absent. In grade 3, it is still 13-14, but focal deficit is present. In grade 4, it is 7-12, and focal deficit can or cannot be present. In grade 5, it is 3-9, and focal deficit can or cannot be present. In order to investigate subarachnoid hemorrhage, we do a CT scan within 12 hours. Its sensitivity decreases after 1 week of bleeding. Then we do a lumbar puncture to analyze the CSF by spectrometry for hemoglobin breakdown. In this, we see the breakdown product oxyhemoglobin and bilirubin. This is detected in a sample for 6 to 12 hours after hemorrhage. After that, we can do catheter angiography. Treatment. First of all, we need to give the patient bed rest, early neurological assessment, strict input and output monitoring, IV fluid replacement with normal saline, oral nimodipine. Dose of this nimodipine should be 60 mg for 4 hours. Then what we have to do is, after resuscitation, our priority should be to prevent bleeding. How do we prevent bleeding? we do a procedure called digital subtraction angiography. This basically assesses if the patient has leak blood or not. If the venous part has been found, we do a craniotomy and clipping or endovascular embolization, also called coiling, or mesh stents are placed. After that has been done, we need to recognize neurological complications such as vasospasm, hydrocephalus, or systemic complications such as electrolyte imbalance, hypertension, cardiac infarct, and arrhythmia. The complication of untreated hemorrhage can be electrolyte imbalance, cardiac arrhythmia, neurogenic pulmonary edema, neurological deterioration that suggests communicating hydrocephalus, and delayed ischemic neurological